Hello, we will discuss the management of class 2 malocclusion. The management depends on the type of malocclusion that we have, whether it is skeletal or dental, also whether it is before the end of growth or during the growth period. So if it is dental, whether we are in the growing or non-growing phase, we do orthodontic treatment in using fixed or removable orthodontic appliances. When it is skeletal, whether it is in the growing or the non-growing phase, in the growing phase, if we have mandibular retrognathism, we use the myofunctional therapy, which are the functional appliances. And if we have maxillary prognathism, we use the headgear to restrict the maxillary growth. And if we have both of them, we use a combination between the headgear and the myofunctional appliances like the activator. If it is skeletal, but we are in the non-growing phase, we will see, do we have a mild or a severe class 2 malocclusion? If it is mild, we tend to use some camouflage orthodontic treatment by extracting some tooth and applying fixed orthodontic forces. If we have a severe class 2 malocclusion, whether it is the maxillary prognathism or mandibular retrognathism, we tend to do surgery. In the maxillary surgery, it can be only surgery, or it can be a combination between surgical approach and extraction of the premolar and do an orthodontic treatment. Here, for the mandibular retrognathism, the surgical approach can be intraolary or extraolary, but the most commonly one is the intraolar bilateral sagittal split osteotomy. Now let's see what are the etiological factors that led to this malocclusion to know what is the appropriate stages of the treatment. The first is the heredity, the genetic and the congenital, where we have the dimensions of the basal bones that contribute to this malocclusion, that they are inherited. For the natal factors, when some damage or fracture happen during the birth delivery to the temporomandibular joint, it can get ankylosed and will lead to underdevelopment of the mandible, which will cause a retroprognathism of the mandible. The postnatal factors is when some traumatic injuries happen, long-term irradiation therapy or oral habits, congenital missing teeth, or anomalies in the teeth shape like the pig-shaped tooth. Here is the class 2, division 1. We can see the overjet and the increased overbite. We can see that the maxillary arch is V-shaped. As for the class 2, division 2, we can see that the main difference is the inclination of the maxillary anterior to the palatal side. So we have a decreased overjet with increased overbite, and the maxillary arch shape is a U-shaped arch. For the treatment, so we have several things to deal with. We must correct the overjet, the overbite, if there any crowding present, and the sagittal relationship of the molars and the canines. The treatment is categorized into a two-phased treatment or a one-phased treatment, and it depends on the age of the patient where we started doing the correction. If the patient was in the early development or growth, which means between 8 to 10 years, we start with an early phase of treatment using functional, orthopedic, and removable appliances. Then we do what is called the late treatment at the age of 11 to 14. The patient exceeded the first primary stage. We do what is called the one-phase treatment, that is between 11 to 14 years of age. Now, the patient came to us. They have class 2, division 1 malocclusion. They are in the mixed dentition, and we want to treat the overjet without extracting any tooth. In this case, we use the functional appliances like the activator before the premolar and the permanent canine erupt. This will reduces the overjet and improves the skeletal pattern. But if we need to extract the tooth, it is usually done after the permanent premolars and molars erupt. Now, how can we reduce the overbite? It can be reduced by using what is called the anterior bite plane with removable orthodontic appliance that reduces the overbite by allowing the vertical development of the posterior dentoalveolar segment. Or we can use fixed orthodontic appliance that do a downward force on the mandibular incisors, so it intrusion them, and we will get an extrusion of the posterior segment, which decreases the overbite. The fixed orthodontic appliance can act on the upward maxillary incisors to cause also some intrusion in them and cause extrusion on the posterior dentoalveolar segment, therefore reducing the overbite. Here are the fixed appliances with the anterior bite plane. We can see here it is applied in the mixed dentition phase where the premolars are about to erupt. Here we can see that extraction of the premolars was indicated to do retroclination of the anterior segment and reducing the overjet. This is the anterior bite plane of a removable appliance, and here we use an intermaxillary elastics to do a bodily movement of the anterior teeth, and it is important to achieve a bodily movement where all of the teeth, root and crown is moved together. Now, how to fix the molar relationship? We have 3 types of choices that need some concentration. We can do 3 types of movements. The first one is a distal movement of the upper posterior teeth. Here we can do some retraction of the upper teeth in order to get class 1 occlusion between the molars, and in these cases we should or we may extract the upper second molar. The second choice is doing mesial movement of the lower posterior teeth, and this will require movement in both arches. Is that we remove the premolar from each side of the upper and lower arches. Then we use an intramaxillary traction to move the upper anterior segment back and the lower posterior segment forward. Here we extract 4 premolars, and we get class 1 molar relationship. The third choice we have is doing the mesial movement of the upper posterior teeth. In this case, we get a class 2 relationship of the. It is indicated when we have severe cases of class 2 division 1 malocclusion. The upper premolar is extracted on each side of the jaw, and the anterior segment is moved back, and the upper posterior segment is forwarded to the space of the extraction using an intramaxillary traction. Now, what is the management of the class 2 division 2 malocclusion? The most important thing is to treat the incisor relationship and to overcome the overbite, and this is happened by doing what is called the anterior bite plane. In some cases where this type of anterior relationship is causing gingival trauma, after we relieve the overbite, we should do permanent retainer to reduce after the reduction of the overbite. That's it.